Assalamu alaikum. Now I would like to talk about some colon pathologies. These are the risk factors for colon cancer. In colon cancer, there are some lifestyle factors, there is some medical or family history, and there are some protective factors. In lifestyle factors, there is frequent consumption of red or processed meat and tobacco alcohol as usual. And medical or family history, personal or family history of FAP, that is adenomatous polyposis or colon cancer, inherited colon cancer syndrome like FAP, familial adenomatous polyposis, and hereditary non-polyposis colorectal cancer like Lynch syndrome, HNPCC, ulcerative colitis where P-ANCA is positive, diabetes and obesity, and prior abdominopelvic radiation. These are the high yield family history risk factor for colon cancer. And the protective factors are NSAID, aspirin use, and the high fiber diet. High fiber diet. These are the risk factor for colon cancer. Now, clinical characteristics of the colon cancer. If there is right-sided colon cancer, there is occult rectal bleeding and iron deficiency. If there is left-sided colon tumor, you may get as a form of hematochezia, that means fresh blood in stool, or visible rectal bleeding, abrupt change in bowel habit, constipation, abrupt change in bowel habit and abrupt change in bowel habit, constipation, and rectal tumor, and you may get as rectal tumor, narrowed stool, tenesmus, defecation pain, sensation of mass or heaviness, or any location, or any location, abdominal pain, unexpected weight loss, and decreased appetite. I have already told you about the risk factor, family history, medical or family history. This is important. Obesity and type 2 diabetes mellitus are associated with increased risk of colorectal cancer. Why? Because type 2 diabetes or obesity causes hyperinsulinemia, and these hyperinsulinemia results in increased circulating insulin-like growth factor, and these increased circulating insulin-like growth factor inhibits epithelial cell apoptosis, inhibit colorectal epithelial cell apoptosis. And if the normal apoptosis function is hampered, then the abnormal things activated. That means there is promotion of neoplastic progression, and that's why obesity and type 2 diabetes mellitus causes increased risk of colorectal cancer. The most common site of colon cancer metastasizes in the liver. This is high yield. The most common site of colon cancer metastasis in the liver. Liver manifests as right upper quadrant pain, mildly elevated liver enzyme, and firm hepatomegaly. Right upper quadrant pain, mildly elevated liver enzyme, and firm hepatomegaly. When metastatic spread is confined to liver, surgical resection of both hepatic mass and the primary tumor can be curative, often provides increased long-term, more than 5 year survival, even not curative. Metastatic resection typically done without chemotherapy unless the tumor is deemed unresectable due to size and the number of the metastatic liver lesion. Chemotherapy is commonly employed to prolong survival in patients with unresectable metastatic colon cancer. So, if the colon cancer is resectable, then we do not need chemotherapy. If the tumor is not resectable at that very time, we need chemotherapy. Combined chemo and radiation are used for non-operable rectal adenocarcinoma. Non-operable rectal adenocarcinoma, in that case, we actually use combined chemo and radiotherapy. And neoadjuvant chemotherapy, that means chemotherapy given before the surgery done. This is called neoadjuvant chemo or radiotherapy. Radiation therapy is typically avoided in tumor proximal to the rectum, because the adverse effect radiation enteritis can be severe. Liver transplantation can help certain individuals with hepatocellular carcinoma. It is contraindicated in patients with non-hepatic tumor, the primary non-hepatic tumor. Liver transplant can help in hepatocellular carcinoma, but it is contraindicated in patients with primary non-hepatic tumor. Sigmoidoscopy is effective tool for evaluating lesion in the distal colon, but does not visualize beyond the rectosigmoid junction. Patient with left-sided adenoma, rectal adenocarcinoma, can be detected on sigmoidoscopy, have increased risk for synchronous neoplasia of right side, and require visualization of the entire colon by the colonoscopy. That means there are two options. It is sigmoidoscopy, there is colonoscopy. In sigmoidoscopy, we can only visualize up to rectosigmoid junction, but in colonoscopy, we can see the whole colon. So better to go through colonoscopy. What are the, which tumor marker is important for seeing the prognosis? CEA, carcinomembranous antigen, is important for seeing prognosis. Imaging CT scan of the chest, abdomen, CT scan of the chest, abdomen, pelvis to see distal metastasis, and endoscopy or direct visualization, colonoscopy. The US United States Preventive Service Task Force strongly encourage routine colon cancer in all patients aged more than 50. The American Cancer Society recommends screening starting at the age 45. Screening started at the age 45. This is high yield, high sensitivity stool based testing, like fecal occult blood test, like fecal immunochemical testing annually. Direct visualization technique, colonoscopy every 10 years and flexible sigmoidoscopy every 5 years. A combination flexible sigmoidoscopy every 10 years with a FIT, that means fecal immunochemical testing. These are the options: high sensitivity, stool-based testing, reg visualization, and a combination. Annual occult blood testing can be used for colon cancer screening in low-risk individual, but in high-risk individual like personal or family history of colon cancer or polyp, it is actually less accurate than colonoscopy in diagnostic the neoplastic lesion. Surveillance after colon cancer resection. Stage 1. Stage 1, involvement of mucosa and submucosa. Colonoscopy in 1 year, then every 3 to 5 years. Colonoscopy in 1 year, first year, and then every 3 to 5 years. Stage 2, involvement of muscularis mucosa and serous. Mucosa, submucosa, involve and muscular smoothness colonoscopy in first year, then every 3 to 5 year, periodic CA testing and annual CT scan of the chest and abdomen. Stage 3, lymph node involvement. Stage 3 lymph node involvement. In that case, you should do this thing: colonoscopy 1 year, then every 3 to 5 year periodic CA testing, annual CT scan of the chest and abdomen, and stage 4 metastasis as individualized. Consider stage 2 and 3 strategy, but more frequent CT scan. This is high yield, more frequent CT scan. So for stage 1, that means involvement into the mucosa and submucosa, you should go through colonoscopy in first year, then you should do colonoscopy every 3 to 5 years, and in stage 2 and 3, colonoscopy in the first year, then every 3 to 5 year periodic C testing and annual CT scan of the chest or abdomen. And in stage 4, consider stage 2 and 3 strategy, but more difficult, but more frequent CT scan. This is colon cancer staging in patient at increased risk. This is another high yield. Family history of FAP or colorectal cancer. Family history of FAP or colorectal cancer, age more than 40 or 10 years before the age of the diagnosis in the affected individual. In first degree relative, age less than 60, two more than two first degree relative at any age, two or more than first degree relative at any age. Repeat every 5 years. Repeat every 5 years. And so if the age of the person is uh, if the age of the person is 38, if the first degree relative has a cancer in 38 years, then you should do colonoscopy before 10 years, that means 28. In case of IBD and ulcerative colitis and Crohn's disease, in ulcerative colitis, patient with disease limited to the rectum and left colon may be gained 12 to 15 years after post-diagnosis. Uh, and Crohn's disease with colonic involvement begin 8 years after the disease onset and repeat 1 to 3 years. If the IBD is diagnosed at the age of 28, then you should start screening from 36. Doing colonoscopy at the age 36, and you have to repeat it 1 to 3 years. Classical FAB age colonoscopy 10 to 12, repeat annually. Classical FAB familial adenomatous polyposis age 10 to 12 and repeat annually. In hereditary non-polyposis age 20 to 25, repeat 1 to 2 years. Classical FAB 10 to 12, non-polyposis 20 to 25, and abdominopelvic radiation screening should commence at an earlier age 30 to 40. In hyperplastic polyp, there are two kinds of polyp, mainly do hyperplastic and hematomas. In hyperplastic and hematomas polyp, what you have to think about in hyperplastic, this is non-neoplastic abnormality often found on screening colonoscopy. Hyperplastic polyp are most common where in the rectosigmoid junction of the colon. Small, less than 1 cm hyperplastic do not increase risk of colon cancer. And therefore patient may continue colorectal screening at usual intervals. Repeat colonoscopy in 10 years for individual at otherwise average risk. Repeat colonoscopy in 5 years in individual with a high risk family history, first degree relative with colorectal cancer less than 60. More frequent screening less than 10 years is indicated in patients with adenomatous polyp with a specific interval dependent on the size and the number. Colonoscopy is recommended for patients who have profuse bleeding and who are at high risk of colorectal cancer includes prior adenomatous polyposis, age more than 50, unless the patient has negative colonoscopy with the last 2 to 3 years, age 40 to 49, in first degree related with the colon cancer, uh, colorectal cancer, age less than 60, and familial colon cancer syndrome. That means Lynch syndrome. These are the polyps. Polyps. Colon polyps are grossly visible with protrusion. Colon polyps are grossly visible protrusion from the flat mucosal surface of the intestine. They are categorized as non-neoplastic, that means hyperplastic, and hematomas, and inflammatory pseudopolyp, and submucosal polyp, and neoplastic polyp. Non-neoplastic hyperplastic polyp arises from hyperplastic mucosal proliferation. Hematomas, juvenile polyposis, Peutz-Jeghers syndrome. These are hematomatous polyp, inflammatory pseudopolyps, submucosal polyp like lipoma and lymphoid aggregates, and neoplastic adenomatous polyp. Finding that suggests that greater risk of malignant transformation, prior villanous or villous structure, particularly in the presence of high-grade dysplasia larger more than 1 cm, more than 1 cm, high number, more than 3 concurrent adenoma, more than 3 concurrent adenoma, prior villous structure larger more than 1 cm, and high number. High number. In addition, sessile non-pedunculated adenomatous polyposis are associated with increased risk of synchronous advanced neoplasia, often careful to ensure complete removal. Sessile adenomatous polyposis are associated with increased risk of synchronous advanced. Then Peutz-Jeghers syndrome. It is autosomal dominant disorder. Tumor suppressor gene mutation causes unregulated tissue growth. Tumor suppressor gene regulation causes unregulated tissue growth. Clinical feature: pigmented macule, lips, buccal mucosa, palms and soul, more than 2 gastrointestinal hematomatous polyps, abdominal pain due to obstruction and intussusception, anemia due to acute or chronic bleeding, rectal prolapse. Abdominal pain, anemia, rectal prolapse. Abdominal pain, anemia, and rectal prolapse increase cancer risk. Gastrointestinal, breast, and genital tract. Positive family history. Positive family history you can diagnose via genetic testing and annual anemia screening, and cancer screening is important. Cancer screening is important. Pigmented macule in the lips, buccal mucous, palms and soul, more than 2 gastrointestinal or hematomatous polyp, more than 2 gastrointestinal or hematomatous. Now, common hereditary cancer syndrome, Lynch syndrome. In Lynch syndrome, the associated neoplasm is colorectal cancer, endometrial cancer, and ovarian cancer. In Lynch syndrome, there is colorectal cancer, endometrial cancer, and ovarian cancer. Colorectal cancer. In fact, there is BCD, brain tumor, colorectal cancer, and desmoid and osteoma. Von Hippel is heart, hemangioblastoma, angiomatosis, renal cell carcinoma, pheochromocytoma in men, pituitary pancreas parathyroid in men, type 2 parathyroid, thyroid, pheochromocytoma, and BRCA1 and 2 breast and ovary. In Lynch syndrome, there is CEO, that means colorectal cancer, endometrial cancer, and ovarian cancer. In Lynch syndrome, hereditary non-polyposis colorectal, it's an autosomal dominant disorder. Genetic testing should be performed in patients with a strong family history, more than 3 relatives involving multiple generations. The condition is due to germline mutation of the DNA mismatch repair gene. Once the diagnosis of the Lynch syndrome is established, patients should undergo screening for colon cancer with colonoscopy. Endometrial cancer screening with annual endometrial biopsy should begin at the age of 30 to 35. Ovarian cancer risk also increase and may present at relatively younger age. Therefore, prophylactic hysterectomy and bilateral oophorectomy is recommended at age 40 and earlier if childbearing is complete. Patients with Lynch syndrome, hereditary non-polyposis colorectal cancer are increased risk for gastric adenocarcinoma and warrant period upper endoscopy to detect the early adenomatous polyp. However, patients typically have an extensive family history of colon, endometrial, and ovarian and stomach cancer across multiple generations. In Lynch syndrome, genetic criteria, patient-based criteria, and family history-based patient-based colorectal cancer, endometrial cancer, and first-degree relative with MMR and EM, EPCAM gene mutation, endometrial carcinoma before age 60, family history-based criteria more than 3 relative with Lynch syndrome associated cancer, more than 3 relative with Lynch syndrome associated cancer, that means colon, breast, that means colon, small bowel, endometrial carcinoma, transitional cell carcinoma, FAP, involves two or more family generation, more than one related diagnosed age 50, more than one related diagnosed age 50. This is the Lynch syndrome genetic screening criteria. Patient-based criteria, colorectal, endometrial cancer, and first-degree relative with MMR or EPCAM gene mutation, family history-based criteria, more than 3 relative with Lynch syndrome and associated cancer, involves uh, 2 or more family generation and 1 or more relatives diagnosed at the age less than 50. Colonic ischemia, usually non-occlusive watershed ischemia, underlying atherosclerotic disease, state of low blood flow, hypovolemia, moderate abdominal pain, moderate abdominal pain and tenderness, hematochezia and diarrhea, leukocytosis and lactic acidosis. Colonic ischemia CT scan perform urgently to identify who needs surgical intervention. Colonic wall thickening and fat stranding, endoscopy to confirm the diagnosis, colonic ischemia confirm the diagnosis, and abdominal radiography is usually normal. Thumb printing is sometimes seen. In colonic ischemia, thumb printing is normally seen. Coronary wall thickening and fat stranding. In management, IV fluid and bowel reset, antibiotics with entire corporation, and colonic resection if necrosis develop. Acute mesenteric ischemia. In acute mesenteric ischemia, rapid onset periumbilical pain, pain out of proportion to examine, finding hematochezia. Risk factor is atherosclerosis, atheroembolic, and embolic source, and hypercoagulable state. In acute mesenteric ischemia, there is periumbilical pain, pain out of proportion to examine, finding hematochezia. Risk factor is atherosclerosis, atheroembolic, embolic source, and hypercoagulation. Lab leukocytosis, hemoconcentration, elevated amylase and phosphate level, and metabolic acidosis, anion gap, elevated lactate. CT or MR angiography, mesenteric angiography. If diagnosis is unclear, management is nasogastric decompression, IV fluid, anticoagulation, drops, hospital, antibiotics. CT will show chronic mesenteric ischemia, atherosclerosis, Clinical feature is crampy, postprandial epigastric pain, food aversion, and weight loss. Diagnosis: signs of malnutrition, abdominal bruit in 50% cases. In chronic mesenteric ischemia, you may get abdominal bruit. CT angiography is preferred, will show narrowing of the celiac and the supramesenteric artery. Doppler ultrasonography can be done. Risk reduction: tobacco reduction, nutritional support, endovascular or open surgical revascularization. Although Clostridium septicum bacteria have colon cancer and therefore colonoscopy is required with no history of the tumor. Bacteria with group T Streptococcus bovis is also strongly associated with colon cancer and should promote screening colonoscopy. So in acute mesenteric ischemia, risk factor is atherosclerosis, atherothrombotic, embolic, and hypercoagulable state. And in chronic, etiology is atherosclerosis only. And in chronic cases, CT angiography is preferred. In acute cases, CT or MR angiography is preferred. Both cases, CT or MR angiography is preferred. And this is all about the colon pathology. I haven't discussed about the rectum. I will discuss it in later videos. Inshallah, you will be benefited.